Thanks again, David, for this kind invitation. So I was tasked today with overviewing the novel therapies for AML and then telling you why you should not use them in, in some of the situations. So I would be focusing more on the off-label indications, or the off-label use of these drugs, because I think the on-label indication should be like the standard of care, and we should be definitely be considering those, strongly when we think about our patients. So you saw this slide earlier, and I think the reason why I like to show it is that the survival of AML patients since the mid-70s until 2009, while still suboptimal, but there has been a significant improvement, around from 6% to 28%. Most of that improvement happened in patients who were younger than 60, and that happened, all of this happened without the addition of new therapies. So when I'm talking today about traditional therapies, I'll be focusing on 7+3 and hypomethylating agents as what I consider traditional therapy, and all the novel therapies was what you heard about earlier today. So you have a significant improvement in survival in younger patients. This is mostly related to best supportive care, better use of antibiotics, wider use of transplant. So we did achieve a lot just by optimizing our traditional therapies. Doesn't mean that we have to stop there, but I think we did a lot, and that's important to think about. You also saw this slide earlier, but even among patients who are 60 to 69-year-old, there has been some improvement. We generally don't think that older patients have significant improvement, but over the years, there has been significant improvement in patients who are 60 to 69 as well. This is another slide that I like to show. As you can see here, this is the 5-year survival probability of multiple hematologic malignancies in the US. What you can see here is that for AML, for younger patients over time, there has been a significant improvement along multiple age groups. This is definitely less than what you are seeing with CML or CLL or ALL, but again, there's a definitive trend for improvement. And all of that happened by optimization of the standard traditional therapies. So Dr. Stone is here, so I don't want to go against midostaurin a lot, but I'd like to say that there are several things that I think we should think about when we think about using midostaurin for our patients. One of them is that when you look at the 4-year overall survival, it's 51% versus 44%. And I like to think about this when each time I talk to a patient about midostaurin. So that's 7.2% absolute risk reduction, meaning that you have to treat 14 patients with the drug to get one patient that will be alive at 4 years. So 13 patients out of the 14 will not derive benefit from the drug. Of course, we have no way of knowing which one out of the 14 is going to be that patient, so we have to treat everybody. But again, I think that's important to put into context in terms of when you think about the drug. We have no idea how to predict the patients who are going to respond, and we have no idea about how the salvage therapy is going to be basically subsequent to midostaurin as the new FLT3 inhibitors become available. This is the maintenance slide that I showed you earlier. Again, we have no idea if doing maintenance really helps the survival in those patients, and this is something that we should think about when we talk to patients. So the use of midostaurin, and I've seen it a lot actually from some of my community colleagues, in which patients put in midostaurin with hypomethylating agents, midostaurin as single agent on older patients, midostaurin in the relapse setting. All of these have very little data, and I don't think these should be used in the absence of clinical trial data, because we don't have any basically data to support using it outside of the combination of 7+3. I would even extend for the midostaurin that the study was in patients who are younger than 60, although the FDA label did not include age. We always say age is a number, but we always understand that the biology of leukemia in older patients is different, and I think we also have to think about that when we think about adding midostaurin for older patients who are fit for chemo. How about CPX? So CPX, I think, again, is a good drug. It was somewhat irritating that there has been no paper for almost 9 months after the approval of the drug, and we are still only looking at the ASCO abstract without any specific subgroup analysis to understand how the drug exactly works. But I want you to encourage you to look at the tail of this curve, basically. So you can see a 9.5 months versus 6-month improvement in median overall survival. But the bottom of the curve, this is very deceiving when you look at it, because if you look at the circled numbers, the patients at risk, the numbers become very small. So this is not a huge difference. If you have confidence interval around the end of the curve, that would not be necessarily significant. So what I mean is that on the long-term survival, whether there's a chance of a higher survival is not necessarily clear. And that's important, again, when you look at these studies. Another point to think about is that the approval from the FDA came for therapy-related AML or AML with myelodysplasia-related changes. However, the study did not include AML with myelodysplasia-related changes. It only included patients who had AML coming out of MDS or patients with AML who have MDS-like karyotypic changes. However, the FDA did include that indication, and I see it being used all the time. What is therapy-related AML? This is another thing that actually kind of drives us, as someone who has done a lot of epidemiology work in AML, I'm showing you here two studies. One of them is in patients who had breast cancer who received radiation therapy alone without chemotherapy. And what you can see that radiation therapy does increase the risk of secondary myeloid neoplasm. However, the absolute risk increase is only 15%, meaning that 85% of patients were going to develop MDS or AML anyway, even if you didn't give them radiation. So we are labeling everybody as therapy-related MDS or therapy-related AML when a large chunk of them would probably have developed it anyway. So I don't think we really understand what is really therapy-related AML and MDS, and we really need to sort this out when we think about why is CPX specifically beneficial for these patients, and how can we really differentiate real therapy-related AML versus AML that happens incidentally in the context of previous therapy. And I give you an example, a patient who I saw 2 weeks ago who had auto-transplant 25 years ago for breast cancer. At that time, they used to do auto-transplant. And now she has AML. And how do you know? Like, she had normal karyotype. So she's not really behaving like therapy-related AML, but according to the WHO criteria, you have to call it therapy-related AML. The reduction in the mortality in the CPX study was largely related to reduction in death, basically from progressive AML in the first 60 days. And again, that's somewhat unusual because we often see a higher infectious disease complication basically in this setting. So I think CPX is an intensive drug, and this is an intensive chemo. So when you use it, you have to use it in patients who are really intensive chemo candidate. And I think that sometimes is not very well understood when patients are giving the drug in the community. Just gonna go over a couple of other slides for the sake of time, but the decitabine data in TP53 mutated AML, as you heard, basically 100% response rate basically when you have TP53 mutated AML. So when you have a patient who have therapy-related AML and they have TP53 mutation, do you really want to use CBX that you have to give the patient in-house for 6 weeks admission and all the risks that come with that? Or would you try to do an outpatient therapy that is less toxic with a good result? So I think, again, this is something that we have to think about when we counsel patients about treatments. In AML, basically, hypomethylating agents actually have reasonable results. This is an AML with myelodysplasia-related changes, in which azacitidine, this is a subgroup analysis, had a median survival of 9 months. And when you think about CPX, basically, you have to think about not only whether should I give 7+3 versus CPX, because this is a fit patient. When you look at the patient, I personally believe that it's not a matter of physical fitness, it's a matter of biological fitness. Is this a type of leukemia that's likely to respond to intensive chemo, or should I be thinking about decitabine or some other type of basically less intensive or trial approach? And of course, as you heard earlier, all these combinations are unproven, basically adding midostaurin to CPX or adding, so these are still not being tested, and I think they should be tested. HMAs in the frontline setting with AML, basically, azacitidine has, in the landmark study by Dr. Dompré, had a median survival of 10.5 months. And I'm going to show you several studies, basically, quickly here. This is CD33 antibody that was tested last 2 years ago, basically, and from called CD33A, and this was presented as a big breakthrough from ASH 2 years ago in the phase 1, because when the drug was added to hypomethylating agent, the CR rate was 60%, but subsequently the phase 3 trial was ended prematurely because there was an increased incidence of death on that trial. So I think we should always think a lot before we use a lot of the phase 1 data to guide our decisions. Gemtuzumab, another drug that I think you have to think about when you want to use it in the frontline setting. Okay, we have a phase 3 trial that shows improved survival in the frontline setting, but when you look at the number, the median survival is 4.9 months, while with the azacitidine is 10 months in older unfit patients. Again, comparison across trial is always very challenging, but something to keep in mind. Adding venetoclax again to low-dose cytarabine or hypomethylating agents, this again has been presented as a very major breakthrough, CR rate of 60%. However, when you look at the median survival with both combinations, the median survival is still 11 to 12 months, not much longer than what we are seeing with single agent azacitidine. So I think there should be a lot of caution about how to use these drugs. I'm just going to give you last couple of slides here. In refractory relapsed AML, we did a retrospective study. One of my fellows basically we got data from Europe and US basically in 600 patients who received hypomethylating agents when they relapsed with their AML. And what we found is basically that the median survival was around 6.5 months, and patients who had a complete response had which was around 15% of patients, had a median survival of around 14 months. So doing hypomethylating agents in the relapse setting is, I think in my mind, is a reasonable thing. When you look at the inacidnib data, for example, 9 months for patients who have the IDH2 mutation. However, and this is one of the things that I never completely understood when the FDA approved the drug as a regular approval rather than accelerated approval, because I think we still don't know if inacidib compared to hypomethylating agents, for example, in the relapse setting does improve survival. And there's an ongoing study, but it's going to suffer a lot from accrual because many centers are not accruing to it after the drug was approved. And this is the last slide, again, showing you some study that is heavily used in the community in which azacitidine is combined with sorafenib based on this trial by Dr. Ravandi. However, again, when you look at the overall response rate, 27% CRI. However, the median duration of response is only 2.3 months. And you see this used all the time, but this median response duration is very minimal, and the median overall survival is 6 months. And I just showed you that in relapsed refractory AML with single agent azacitidine, we were seeing a median survival of 6 months. So does really adding sorafenib, add much here? The IDH inhibitors, I'm not going to go over this because of time, but again, we never think about cost, but cost is something we have to think about. Inacidib, I looked up this basically in the internet, basically, and $25,000 per 1 month supply. CPX, around $10,000 per vial. Midostaurin, $15,000 per 1 month, and gemtuzumab, $25,000 per cycle. So you are talking about hundreds of thousands of dollars for each patient, and I think we really need to make sure that we are getting, at the cost of the society, basically, that we are getting good results when we're using them off-label in which we don't have very good data. Thank you so much.